Hello, good afternoon to all of you. Let me thank you, Dr. Ashwini, for a wonderful uh, introduction of Hate Sir and me and mine. Uh, First of all, I would like to extend my apologies to all of you that today's session was about to get delivered by Hate Sir, but he is hospitalized. He has to be hospitalized due to an certain medical condition. So we wish for his speedy recovery. And sir, as sir always say, that the show must go on. So I would be taking the webinar of 40 minutes on pelvic floor, a unique opportunity for physical therapist. So let me have my screen sharing on. So my today's topic is pelvic floor rehabilitation, a unique opportunity for physical therapist. Uh, Let me quickly tell what agenda of today's webinar would be, what you should be expecting from me. So first and the foremost thing is I would like to introduce sir again, but as Dr. Ashwini has already introduced sir in a very nice way. So after that, we will be going for integration of core muscle. How does transversus abdominis, multifidus, diaphragm, pelvic floor, they work together? What is the relationship between these muscles? We say core. We say we need to strengthen core in back pain patient to increase the back stability. But what exactly does core integration or what exactly does core rehab means? Do we only by doing Kegels is that enough? How can pelvic floor integration or how can pelvic floor rehab help in this? That will be that we would be discussing. Other than that, we would be after that we will be taking a short case study which will help you to understand that how can we integrate um, pelvic floor rehabilitation with low back pain. Followed by that, we will be seeing about wow pf 360 and how can you get yourself benefited by adding pelvic floor rehab in your current practice. So yes, Sir is an entrepreneur, author, and innovator. He is popularly known as father of modern pelvic floor rehabilitation. And our vision is to courageously break the cultural taboo and to make the pelvic floor health, the core health, and the core rehab accessible to every single woman and every single man all across the globe through innovative technologies and services. So once again, a warm welcome to all of you for KLE conference, and I congratulate KLE team for organizing a wonderful virtual conference like this. So going ahead with our today's topic, that is relationship of diaphragm, abdominals and pelvic floor muscles. How does diaphragm, pelvic floor and abdominal muscles do integrate with one another? What is the what how is their integration taking place? So let me just show you the pelvic model, which I'm just stopping my screen sharing. So this is the pelvic floor, okay, the model of the pelvis. Fine. So here you can see that you have an symphysis pubis, you have ASIS. Can I just pin my video? Let me pin my video so you all can see it. Yeah. So it is symphysis pubis. Symphysis here it is right and the left ASIS. Okay. Just if I just rotate the pelvic model, we have the sacrum and the coccyx. Right. So if you can see here, the whole pubis to coccyx का area is covered by the pelvic floor muscles. Okay, it supports the pelvic cavity, it supports the pelvic content, it supports the pelvic organs. Okay, so these are the pelvic floor muscles. And just anterior or just above the symphysis pubis, we have the transversus abdominis muscle. Just posterior to just posteriorly near on the vertebral, we have the multifidus muscle. Okay, and above we have the diaphragm. So these four muscles, nowadays people also say that gluteus is the new core, but the actual core which we talk about is the diaphragm at the top, the transversus abdominis, the pelvic floor and the multifidus. How does Heitzer makes people understand the core is, he says that you assume that you yourself are sitting at the back wall, which with the support of which you are sitting, the back wall is your multifidus. The front wall which you are seeing, the whole front and the side walls, they are your transversus abdominis. The ceiling where the fan is hanging is your diaphragm, and the foot and the floor on which your foot are resting, they are the pelvic floor. Okay, so likewise these four muscles are integrated. And how is the relationship between diaphragm and pelvic floor muscles? How do it work together? What should actually be the diaphragmatic movement along with the pelvic floor movement? So let me explain you that. When we talk about the diaphragm and the pelvic floor, okay, which lies the diaphragm which lies here and the pelvic floor which is beneath. So like this we have the integrate the diaphragm and the pelvic floor. So whenever the diaphragm is coming into contraction, whenever the diaphragm contracts means we inhale. Okay, we inhale, so the central tendon of the diaphragm would descend down into the abdominal cavity. Okay, the central tendon would descend down into the abdominal cavity. This will cause increase in the intra-abdominal pressure. So in order to maintain the intra-abdominal pressure, what does the pelvic floor do? So in order to maintain the intra-abdominal pressure, the pelvic floor should relax. Then and only then the pressure relationship between the diaphragm and the pelvic floor would be maintained. So in order to maintain the relationship between the diaphragm and the pelvic floor, which is the pressure relationship, it is like when the diaphragm contracts, the pelvic floor relaxes, and when the diaphragm relaxes, the pelvic floor contracts. So that is why we generally say that exhale when you exert, or exert when you exhale. Okay, whenever you are exerting, you should exhale, right? So similarly, whenever you are doing pelvic floor contractions, you should teach your patients pelvic floor contractions with breathing out, because that is how the diaphragm and pelvic floor integration is. Fine. So you can understand it by taking a simple example of cuffing. So if I ask you all to cuff and you all are cuffing, so you just try to close your eyes and visualize what is happening at your diaphragm, at your pelvic floor. And then we would integrate the transversus abdominis and the multifidus. Okay. So all of you try to cuff. Take a deep breath in and cuff. So whenever you will take a deep breath in and then you are coughing out loudly, that is a forceful exhalation with open glottis, that is cough. Okay, you would feel that the pelvic floor is contracting. Why does the pelvic floor has to contract? It has to contract because it has to oppose the sudden increase in the intra-abdominal pressure. If the pelvic floor don't contract while coughing, it would lead to leakage, it would lead to prolapse, it would lead to pelvic floor dysfunction. Okay, so first and the foremost is the relationship between the diaphragm and the pelvic floor. Second comes the integration of the diaphragm, the transversus abdominis, the multifidus, and the pelvic floor. Now we say, now when we talk about the interrelationship between these four muscles, they are the core muscles. What is the function of core? Right, first of all we need to understand that what is the function of core. So the function of core is to maintain the stability of the body. You need a stable core, or you need a strong core to maintain the stability. Until and unless your core is not strong, you will have issues with back pain, you will have issues with um, pelvic rotations, pelvic tilting, and not just back pain and pelvic tilting. You might even end up into other dysfunctions also, right? So these four muscles, they work in order to maintain the intra-abdominal pressure such that the spinal stability can be established. Okay, now in order to understand this, let us see a model. So this is what I these are the this is the superior view of the pelvic floor muscles. So superior view of the pelvic floor muscles, when we say, it is like, if I have to show you on the model, it is like from inside. Okay, their pelvic floor are they don't just consist of the levator ani, but they consist of a superficial layer, the middle layer, and then comes the deep layer, the deepest layer, which is known as the levator ani. This layer, okay, this layer, fine. So that is the levator ani. Now, this I was talking about. This is the canister model to prove the postural stability. The canister model to prove the postural stability. So here it is describing the diaphragm, pelvic floor, transversus abdominis, and multifidus. You think that if your abdominal muscles, they are contracting too much, and you are applying a pressure from the diaphragm, you are closing the pressure from the diaphragm. I mean, you are going for an hold, like closing the diaphragm and closing the pelvic floor. What would happen? All of you try to do is take a deep breath in, contract your abdominals, and squeeze your pelvic floor. You will feel an undue pressure on your spine. You will feel an undue pressure in your whole abdominal area, right? So that should not be the thing. Instead, you should have a coordinated movement of the diaphragm and the pelvic floor muscles. Of the diaphragm and the pelvic floor muscles. Now, this is what is the missing link. What we are generally practicing in our low back pain cases, or in the as we always say that low back pain, knee pain, neck pain, they are like the bread and butter for physios. Right from the second year, you might have started treating the patients with low back pain. If nothing, then at least we go for pain management. But do we try to find the exact cause of low back pain? Do we try to assess that what is leading to it? What is the pelvic stability of the patient? How is the diaphragmatic movement of the patient? Whether the patient is a chest breather or the patient is an abdominal breather. Okay, what about his posture? What about his lumbar lordosis? We are somehow trying to overlook these aspects. Okay, so that is what is needed to explore. Going to the next slide, this is an image which is showing an open Caesar posture and an actual posture. So ideally, this should be the thing, that the diaphragm, when it is contracting, your pelvic floor should relax, your abdominals should be contracted. If you see the respiratory physiology, it's like whenever you go for a deep breath in, your abdominal muscles will not be electrically silent. Your abdominal muscles will be contracting in order to maintain, or in order to give a room for the diaphragm to descend. And that is the reason why many paraplegic patients whose abdominal muscles are not strong, or they are not innervated, they have a problem with diaphragmatic breathing. We give them core set and then we have them do breathing. There are a lot many studies on this, right? So whenever you are going for taking a deep breath in, your diaphragm is descending. At that time, your abdominal muscles would also be working, they would also be contracting. Okay, and your pelvic floor should relax. Then and only then you will be able to maintain a proper core stability or a proper intra-abdominal pressure. Otherwise you would be ending up into valsalva. Okay, what is an open posture? What is an open Caesar posture? And that is in faulty posture. Along with, see, we give a very important we give a very much important to the genders lower cross syndrome, or lower cross syndrome, which is visible here. The lower cross syndrome, or sorry, the yes, lower cross syndrome, or where there is an anterior pelvic tilt, which leads to lengthened abdominals, lengthened back extensors, tightened hip flexors, and tightened back extensors. So that is gender's lower cross syndrome. But along with that, if we have a disproportionate functioning of diaphragm, okay, anterior flaring of the ribs, excessive flaring of the ribs because of inappropriate functioning of the diaphragm and the posture, then that is known as an open Caesar posture. And this open Caesar posture is found in many athletes, which leads to further hamstring disturbances or further athletic disturbances, knee pain or hamstring stretches or hamstring strains. Okay, so this is a thing which also should be addressed. Going towards the case study, as we don't have much of the time, have to wind it up by 1:40, we would be quickly looking into the case study and how do we take care of the case study. So My case study is of Rita, who is 35 years old, married since 10 years, and she's a mother of two 8-year-old and 5-year-old son. Now she works as a receptionist, and she has low back pain since 3 years. She consulted many orthopedics and physiotherapists, and she always had an intermittent pain. So whenever she had pain, she used to contact a physio, and she used to take the treatment for the pain relief. But again, as she stopped the treatment, she stopped the physiotherapy, her pain used to increase, and the pain used to get aggravated, especially in prolonged sitting, heavy weight lifting, and household activities. Okay, and it was been relieved by rest and NSAIDs. Now, assessment which we all are doing, we find the body type, her body type of ectomorphic. She had a hypolordotic posture with an anterior pelvic tilt, that is Jenda's lower cross syndrome. Her pain assessment was 8 out of 10 on NPRS, which was in dull aching type of pain. Her MMT had shown the weakness of abdominals, glutes, and quadratus lumborum. Her lumbar movement, the lumbar extension was painful. It was restricted also, and she has tightness of piriformis and hip flexors. Okay, we ruled out the neurological issues by doing slum test and SLR, and both were negative. So it showed that it was in completely postural or mechanical low back pain. Right, so this is what we generally do, and we also try to find out that what is the joint mobility, which segment is hypomobile, and we try to correct that hypomobile joint segment. But a thing which is missing here is pelvic floor assessment. As we just understood in the previous slides, that pelvic floor functioning plays a very important role in maintaining the core stability. So if you are missing pelvic floor, you are really missing really missing an important link to treat the core. Okay, because pelvic floor is one of the core. Right. So what we do in our pelvic floor assessment, we generally do HATES MMT, we do HATES surf assessment, we do HATES ring clock assessment. So I would not be going in detail of all the assessment, but I would like to show you all what HATES MMT is and how can you do HATES MMT. So before that, the grade of Rita on HATES MMT was 1 out of 3 and -3 out of -3. 1 out of 3, we mean it is an extremely weak pelvic floor muscles. And whenever we are going for MMT of pelvic floor muscles, the most common MMT grade which comes to our mind is the modified Oxford MMT. But what Sir understood, or what he deciphered by modified Oxford MMT, was by due respect to the grade, it is a wonderful grade. It helped us quite for a long time to deal with the hypotonous pelvic floor muscles. But as it is an era of evolution, we have to evolve, we have to revolve. Okay, so Sir found out that modified Oxford MMT is a wonderful scale, but it has two limitations. First being, it is not giving you the idea of how tight the pelvic floor muscles are. So it can be used to assess the weakness of pelvic floor, but it cannot be used to assess the tightness of pelvic floor. So this is one of the limitation, and the other limitation is in modified Oxford MMT we have the grades like weak, moderate, fair, or poor. Now it is very much subjective. Something which is weak for me might be fair for you, might be poor for someone else, or might be moderate. So it is a subjective grade. We need to actually understand that one, what do we mean by one, two, what do we mean by two, and three, what do we mean by three, and along with that, what do we mean by pelvic floor relaxation. So that is how HATES MMT was developed. So in HATES MMT, what do we do is, first of all, we check the grades for hypertonous pelvic floor for pain in the pelvic floor. So that is, we start from -1, -2, and -3. Whenever you are examining a patient and for a per vaginal examination, and the patient is not allowing you to penetrate because of pain, tightness, or discomfort, that is known as -1, inability to penetrate. -2 is symptomatic penetration. Penetration is possible, but it is with pain, with tightness, and with discomfort. That is -2, symptomatic penetration. And -3 is a complete pain-free penetration. Patient can easily allow you to penetrate and assess herself. So that is -3, asymptomatic penetration. Followed by that, we have 1, 2, and 3. So 1, 2, and 3 means once the patient is Once you are going for invasive assessment, you are inside and you can feel pressure, you can feel contraction from any one side. The contraction is present, but it is present from any one side. That is one. If there is a circumferential grip, that is two. And if there is a circumferential grip and upwards and inwards pull, it is three. So minus 1 means no penetration, minus 2 means painful penetration, minus 3 means easy penetration, 1 means contraction from either side, 2 means a circumferential grip, and 3 means an upwards and inwards pull. So this is how a simplified MMT scale is developed for pelvic floor muscles, and this is what we are using into our clinical practice. So what I want to decipher here or infer here, that we all are doing routine physiotherapy in the form of back pain. So we go for manual therapy, we go for exercise therapy, we go for modalities, mobilizations, XYZ, spinal compression and everything. But if we are unable to diagnose the root cause, if we are missing out an important link to treat, then the back pain might come again and again. The patient might get discomfort again and again. Okay, so you need to assess the whole ABCD of core. And we are assessing, if we are assessing all ABCD of core, then we need to give in prime importance for the part D also, their pelvic floor muscles also. Okay, so, how can you integrate pelvic floor in three magical steps? You might feel that if you have not done pelvic floor rehabilitation, if you are not an OBGYN expert or pelvic floor specialist, how would you integrate pelvic floor? Should you advise Kegels? Are Kegels the only solution for pelvic floor? The answer is a no, right? You might find that if you just search that how many people do Kegel in a wrong way, you would be surprised to find that almost 99.97% people they do Kegels in a wrong way because they are never been taught correctly. They are just told that stop as if you are trying to hold the urine. Now you don't know how the patient is going to do it. Many a times they would end up into accessory muscle use. Stop contracting or tightening the glutes, adducting. So these are the false way to trigger your pelvic floor. Instead, you can use three magical steps or three easy steps to integrate PFM. First and the foremost is patient education. Spend 5, 10, 15 minutes in educating the patient about core. What do you mean by core? Does it only mean TA and MF? No, it means TA, diaphragm, MF, and pelvic floor, right? So explain all these four muscles. Tell her, whoever you are seeing, whichever patient with back pain you are seeing, try to tell her about pelvic floor muscles. Educate her about her intimate muscles. Okay, and you believe me, spending 5 minutes of time in this will give you better output at the end. The second is activating the pelvic floor muscles. So you can easily activate the pelvic floor muscles by a magical technology, that is WOW PF360. Now WOW PF360 is a non-invasive pelvic floor technology which has a brain and the body part. Okay, so this is the brain, the mobile, and the body part. Okay, so we have wonderful integration of all the protocols which are required to use, and I would like to show you a demo, a quick demo of it. So for that I am just simply keeping my audio video off. We'll start it as soon as we take the positioning. So as you can see here, the perineum is visible. You can see there is you can see perineum. And now just over the perineum, how would you palpate the perineum? So that you can say that between the birth hole and the poop hole, just place three finger and the middle finger would be the perineum. On the perineum, simply try to keep the wow PF360. Okay, keep the wow PF360 at the perineal area and start the remote which is visible here. So this will give you an audio, video, and auditory, video, visual, and tactile stimulation for the perineal muscles to get stimulated. Okay, so this is an easiest way to activate the pelvic floor muscles. Let me show you the functionality again on the model. So what I did was I simply stimulated over the perineal body. I simply stimulated by using the WOW PF360 over the perineal body. And as you can see here, already you have the options available like strength protocol, Glazer's protocol, strength and hypertrophy, endurance, and hypertrophy protocol. So there are already inbuilt protocol along with the given intensities which you can set according to the need of your patient. Okay, so here I have kept an wheel and axle model where if you just stimulate the perineal body, you will get an overall activation. Would like to add one thing over here is like this is an basic model which has to be used if you are not a pelvic floor rehab specialist. But if you are a pelvic floor rehab specialist, make sure you are using the detailed assessment and management for it. Otherwise, simply by using WOW PF360, by activating the perineal body, you can treat the patients with low back pain and can have wonderful integration of pelvic floor. Okay, at the end you can give them home exercise plan through WOW group mobile application, which is completely free of cost. So the patient just has to download the WOW Group mobile application and they can start with the home exercise plan. So, just asking them to do Kegels randomly, or you ask them to do Kegels with the help of an audio visual input. So an audio visual input for Kegels would always give you better results. So this was the prognosis, which I'm not going to go in detail. You all might be getting it. And now the question comes that what would you earn by adding the core pelvic floor rehab in your routine cases? So you will get customer loyalty. You will not just satisfy your customer, you will create loyal customers. Okay, so you will have a better core stabilization, you will earn customer loyalty, you will have internal referrals, you will have external referrals. Okay, so what do you mean by unique reputation or your customer royalty? So Rita, she told us that I had been to 4 physios and 3 orthos, but no one explained me the core and pelvic floor in detail. I feel so lucky that I meet a physio like you. It's because of you that I realize the role of my private muscles in back pain. So even you can stand out compared to other physios. That is gaining a unique reputation. Internal referrals. I did not tell you as I was not comfortable talking about it, but I have urine leakage too. So you see, your back pain patient only turned into your pelvic floor patient. You need not have to go outside and search for the pelvic floor patients. You can easily get internal referrals and external referrals. That is, she referred multiple patients to our clinic as she didn't become just a customer, she became a fan. So that is what is satisfied customer or customer loyalty. Yes, I would like to repeat it again that pelvic floor is an ocean. We cannot cover it in 40 minutes. So there are a lot many things you can learn. You can join us to understand what pelvic floor rehab is, how can you be specialized in it, and how can you diagnose different dysfunctions. But just to have 3 easy step strategy, simple, easy, and highly efficient. If you are ever treating back pain patient, add core into it. If you are adding core, don't forget pelvic floor. If you are adding pelvic floor, buy WOW PF360, the ultimate core exerciser. And once you buy it, start the training with strength protocol for 5 minutes as a home exercise plan. So it will help you to satisfy your customer, to explain them, to gain unique reputation for internal reference, for external reference, and you will completely explore a new dimension in your already established practice. So this is all about from my end. If you want to know more, this is my contact number. You can contact me.